Hi, I'm Dr. Gillogly. I'm the president of Atlanta Sports Medicine and Orthopedic Center and also the director of the Cartilage Restoration Center here at Atlanta Sports Medicine. What I'm going to talk about in this presentation is treatment of articular cartilage injuries in the knee. Articular cartilage injuries, I'm going to define what they are. I'm going to also start by just the basics of what cartilage is and then talk about some parameters of treatment, show a little bit of the various treatment options, and just give this as a primer to treatment of articular cartilage injuries. First, we'll look at knee anatomy. The knee is made up of multiple different surfaces. The articular cartilage is the smooth white lining that you see if you tear apart a chicken bone or a turkey bone. You'll see a glistening surface. That's what articular cartilage is. And it covers actually each of the joints, but particularly in the knee. The knee has several different surfaces. The kneecap or the patella rides back and forth in a groove in the knee called the trochlea. The trochlea is basically a groove that the kneecap goes back and forth as you move your knee from full extension to flexion. The other surfaces that are important are the femoral condyles, which is there's a medial and a lateral femoral condyle. That's your femur bone, your thigh bone, and it articulates on the tibia. The tibia is the shin bone. It also has articular cartilage on it, and sitting in between those two bones is the meniscus. The meniscus is kind of a fibrous, gristly pad, and it's not what we're going to talk about in this presentation. We're going to talk about the articular cartilage. So what articular cartilage does, it's actually made up mostly of what's called matrix. There's about 5% of this surface is the cells, and each of these cells make matrix. And as they make matrix, it spills out into the in the surrounding area, and that's actually the stuff that you see. The white is really the matrix. So it's like bricks and mortar. The cells are the bricks, and the mortar is what the matrix is, and that's actually what provides the function. Well, this is a pretty unique function in human anatomy. It has 1/7 the friction of ice on ice. So it's 7 times slipperier than two pieces of ice rubbing together. So it's pretty great stuff, and really rivals anything that man can even make at this point. What its primary function is load distribution. It protects the bone of the joint. Throughout running and sports events and all those kinds of things. It protects the bone from where actually the pain fibers are in the bone. It also enhances range of motion by gliding and allowing for smooth motion as you move back and forth. And articular cartilage is very, very durable unless it gets injured. And by injury, something that's a separate force, but in the absence of injury, it actually lasts well over a lifetime. It has a half-life of 114 years, which is incredible that it can last that long unless it's been injured by some kind of event. Now, the problem is there's no intrinsic repair of the articular cartilage. When articular cartilage gets hurt, or has a divot like a pothole in the road, articular cartilage has no blood vessels, it has no nerve supply, and so it really doesn't heal. There's no healing pump that occurs in this articular cartilage because the cells and the matrix, they turn over so slow that they just really can't elicit any kind of a response. Well, you take that and the fact that most articular cartilage problems occur in young people, young active people, now it starts to become a problem because once cartilage is injured, it doesn't repair itself, therefore it tends to go the other way. It tends to get bigger, become more involved in the joint, and that's what leads to early arthritis and further disability or further problems with function. Now, the incidence of cartilage injuries, very, very frequent. Almost 10% of all the arthroscopies. Arthroscopy is the procedure that I'm sure most of you have heard of, where we insert a small scope, a small telescope with a movie camera connected to it inside the knee. We can put tools inside. We do ligament reconstructions and almost everything we can do through a scope inside the knee. Well, 10% of all those arthroscopies, of which there's in the millions done every year in the United States, 10% in patients who are less than 50 will show substantial damage to the articular cartilage. About 7 to 8% will actually have full thickness cartilage problems. This can cause pain and disability. It can cause persistent swelling. It can cause giving way, and ultimately it limits potential for employment, sports participation, and even pain on activities of daily living. Now, this is a quote that sort of underscores the significance of this problem that occurs in young people. Basically, a study looked from Scandinavia looked at people who had articular cartilage problems and compared them to an older population that was getting ready to have total joint replacement, and found that the damage, that the effects on everyday life, even everyday activities, were very, very similar with patients who had just a focal cartilage injury or articular cartilage injury in the knee, and someone who had such advanced arthritis that they were going to have a knee replacement. So it really shows with the significance of it. Well, the goals of cartilage repair, obviously we'd like to restore that smooth surface that's in there, and fortunately there are ways that we can come close. We want to relieve patient symptoms and improve function. Obviously that's the foremost thing. We'd like to have match those properties of protecting the bone, and then we'd like to hopefully slow that progression that I talked about before, the progression to early arthritis. Those are really what we're trying to do. And fortunately, we have ways to do it. Here's a picture. There's a cartilage defect in the upper right, and then it's treated with autologous chondrocytes. That's where we actually grew cells outside in a lab that we took from the patient, came back, put those cells in, and you can see how smooth that surface looks and how it's completely filled in a year after treatment. Well, what kind of things do we need to know as we evaluate patients with articular cartilage injuries? We want to know the size and location of the cartilage injury. Is it 1 or is it 3 or is it 2 defects inside the knee? We want to see what the alignment is. Is the person bow-legged or knock-kneed? Do they have a kneecap that slips in and out of place? All these things can affect the environment inside the knee. We also want to know what the ligament exam is like. Do they have problems with the anterocruciate ligament? Is the knee giving out because of a ligament injury? If any of these circumstances occur, then the environment inside the knee is hostile, and anything you try to do to repair the articular cartilage is most likely not going to work. It would be like if the front end, if the steering was off on your car and it pulled to the right and your tires wore out because it pulled to the right, if you put on the brand new fanciest tires you can buy, guess what? They're going to wear out again because you didn't fix the alignment, you didn't fix the steering. So the same thing is true in the knee. Whatever is wrong, we've got to fix before we have a chance to be able to improve the surface or the articular cartilage. So that's really the simple analogy to keep in mind. We'll take x-rays, we'll look at video pictures. Ultimately, we'd like to look MRI oftentimes. We want to correlate that with physical examination. It's important that it correlates with where the patient's having pain. And then ultimately, we get a chance to look inside the knee and evaluate for possible other treatments, be able to decide what the best thing is, or in the case of autologous chondrocyte implantation, or ACI, we'll actually take a sample of the tissue to be able to grow the cells in a lab and come back and fix the problem at a later time. So this slide just really kind of shows the overlapping pathology that occurs inside the knee. Cartilage defects, of which there's a picture 3 different kinds there, is affected by instability, that's ligament problems. Meniscus deficiency, if you've lost your meniscus before, that increases the load in the knee and makes it a hostile environment. Or malalignment, such as bow-legged, or the kneecap coming out of place, as it shows in those 2 x-ray pictures. All these things have to be treated, have to be addressed, and have to be optimized in order to have a chance of repairing the articular cartilage. Now, from a non-operative standpoint, what do? Rest and rehabilitation, obviously, first and foremost. Non-steroidal anti-inflammatories would be another option. That's your medications like Advil or Aleve, chondroprotective supplements, that's glucosamine and chondroitin sulfate, visco supplementation, that's names like Synvisc or Euflexa or Halgan, some slippery, oily type stuff that we put inside the knee to help coat the surfaces inside the knee and help stimulate the body to make more normal joint fluid when you have early arthritis. Bracing, cortisone injections can also happen. Weight reduction, very, very important. Studies show that as little as 10 to 15 pounds of weight loss improves function in the knee because it decreases the load across the knee and decreases the overall pain. And then ultimately activity modification. Someone who is unable to run 5 miles might be able to bike, might be able to swim, other things for cardiovascular fitness. If they just modify their activities, they can still stay in shape and accomplish some of the same goals that they might have. Now, what goes into the decision making of how to treat cartilage defects? Well, it turns out that size makes a difference. Small lesions is not the same as large lesions. And the location is also something that makes a difference. The patella and trochlea, that's the kneecap and the groove, the kneecaps, they're different than the femoral condyles. The patella and trochlea see what are called shear forces. It's kind of brushing back and forth, whereas your femur, your femoral condyle, you stand on that, you walk on that. That's compressive load. Different types loads make different treatments be the ideal treatment. And then also size, we have a cutoff between smaller than 2 squared centimeters or larger than 2 square centimeters. And that's really the difference. And there's some examples that I've shown there on the right of your slide. So in small defects that are less than 2 centimeters, a number of options are available. Something called debridement or chondroplasty. You can do transfers of tissue called osteochondral transfers, where you take a little plug like an apple core, take an apple core of a good place in the knee and take an apple core in the bad place, leave a hole, put the new hole of the good tissue, the little core inside where the defect is, and that can be an immediate treatment. Only good for small lesions less than 2 square centimeters, where 1 or 2 of these plugs might work. Additionally, for small lesions, another technique works called marrowstimulation or microfracture, and that's where small holes are punctured in the bone and allows for stem cells inside the bone to grow and make some kind of a repair tissue over the defect. However, because the bone is affected by the microfracture, you have to make certain that it's only for small lesions. Otherwise, the bone changes so much inside the knee that it throws off the mechanics and changes the environment, changes the stiffness of the bone, and that can actually cause more trouble down the road. Large defects, greater than 2 square centimeters, the treatment that seems to work the best and have the longest durability, now almost 18 years in the world's literature, showing that results can be consistent for that kind of time, is autologous chondrocyte implantation. That's where cells are grown from the patient, put inside the defect, put inside the pothole, covered with a membrane, and then those cells set up on the bone and grow into repair tissue, much like you had when you were a baby. Not quite as good as original equipment, but pretty darn close many times. Another treatment that's used, particularly when patients have both cartilage problems and bony problems, is something called osteochondral transfers with allograft or cadaver tissue. That's the same idea of taking those cores, like the apple core, but now a much bigger one, because you can obviously take a bigger one from donated tissue as opposed to when you're trying to harvest it from your own tissue. Now, in each of these cases, it's important that the knee be as close to normal as possible, with alignment, stability, the status of the meniscus as well, as I mentioned before. And then location. The femoral condyles, that's the compression where you walk on those, doesn't equal the patellofemoral joint. So some treatments work in one place but not the other. And particularly the ones underneath the kneecap and the trochlea Many of the techniques such as microfracture, debridement don't seem to work in that location. Fortunately, the cells are very, very good for below the kneecap or the trochlea and have 80% plus good and excellent results for those locations. In the big areas of the knee, femoral condyles, oats, allograft, that's the transfers, the big dowels, like the apple core. Those will work for the femoral condyle, but not so much for the patella and the trochlea. So these are all things that have to be thought about in determining the best treatment. Now, from a surgical standpoint, the treatments are basically arthroscopic debridement or chondroplasty. That just means, debridement means removing the damaged tissue, removing the loose fragments that are there, and just cleaning up the surfaces, oftentimes getting rid of these degradative enzymes. Tissue that's causing sort of inflammation inside the knee will improve symptoms. Doesn't change the fact that you still have a defect, but it'll improve symptoms, and sometimes that'll buy patients time for potentially other treatments down the road. Another treatment that's typically used is this marrow stimulation, most frequently used with this microfracture. It's okay in select situations, but if it's used for large lesions or in lesions of the patella or the trochlea, the results are actually poor. Might start off good for 12 months, but then deteriorate rapidly by as early as 18 months, and unfortunately the patient's not even back to where they started from. Sometimes they're much worse. So used correctly, it can be a valuable tool, but used incorrectly, it can actually cause trouble. Then the osteochondral transfers, those are the apple core type things. Autograft just means from your own body. Allograft means from someone else's body. And then the final one is autologous chondrocyte implantation. So going through these options, debridement and chondroplasty, that's the simple thing. It's very easy to perform, doesn't violate the bone. It does provide temporary pain relief. Its limitations, it doesn't really restore normal tissue, so it has low prospects for long-term results. It's more of a short-term result that can clearly improve over the 18 months to 3-year time frame, maybe even up to 5 years in some cases. Now, microfracture, this is, you see examples there of, on the right, of a little, like an ice pick, putting little holes in the bone. The idea is the blood in the marrow below the surface of the bone comes up and fills those little cracks. It's relatively simple to do. It does require extensive rehabilitation. The system's described as having to be on crutches for 4 to 6 weeks or even 6 weeks, to be in a machine that moves the knee back and forth for 6 to 8 hours a day. So it's pretty arduous to go through technically the way you should. It's also not the best treatment for the kneecap or the trochlea, as I mentioned before, and it can, in about 30% of the cases, promote changes in the bone where the bone actually makes a spur right in the middle of the joint. It's called an osteophyte, an intralesional osteophyte. Again, for small lesions, it does provide temporary relief, but the prospects for long-term durability are unfortunately poor. Osteochondral autograft. So here's taking these little dowels and putting them in. You see a couple of examples there on the right. Its limitations is it only works for smaller defects. It won't work for large ones because you can only take so much from one place in your knee that you don't need it and be able to put it in someplace else. It's important that the technique, that you get congruity, that the surfaces still matching up. You don't want to have a cobblestone type appearance where one plugs at one level, another plugs at a different level. That creates real issues. So in general, most surgeons would really only use 1 or 2 plugs in this technique. Anything larger than that needs a different treatment. Well, in some cases, particularly for patients who are a little older, who need for perhaps just a one-stage procedure, this osteochondral allograft is a treatment. So here's, in this example here, you'll see that the defect has now been made into essentially a bony cavity, and then from the cadaver, one cuts the exact same size of a plug with cartilage and bone on it, and then puts it right into where the defect is, and you immediately get a smooth surface. And the bone of the cadaver needs to heal to the bone of the patient, which takes variably some degree of time. It's important that the cells be alive in the transferred tissue. So the transferred tissue only has about 30-day shelf life that you can get this in. Frequently, patients who have this treatment will be on a short notice of, hey, we found tissue that matches, we can put this in the next 10 days, and that's it. If it doesn't work, then they have to move further down the list and can come back and have it done at some point in the future. And then autologous chondrocyte implantation. This, fortunately, is good for large defects anywhere in the knee, but particularly on the femur, as well as on the patella or the kneecap and the trochlea. Its strengths are it has no size limitation. In fact, small lesions and large lesions do equally well. It's durable, has long-term results. Of patients who were doing well at 2 years, 97% were doing well at 8 years in long-term follow-up. So that's the kind of value that we really see, where the cost effectiveness of the treatment withstands the test of time, and someone can still be functional a decade, even up to 2 decades later, that we know of. And it's applicable for all areas of the knee. Its limitation, it does have a high cost. Most insurance programs have a plan for this that includes certain inclusion criterion and allow it to happen. And it can be an excellent option for patients who have large lesions, large chondral or articular cartilage lesions inside the knee. So in summary, the treatment must be individualized for each patient. Not all are the same. Age makes a difference, size of the defect makes a difference, location makes a difference, and additional knee problems also need to be corrected either at the same time or within the same time frame to make the best environment inside the knee to give the cartilage repair the best chance and the patient the best prognosis. Thank you.